background just on the prostate itself. Prostate's part of the urethra, right? So it's actually responsible for two main things, right? One is controlling urine, and then two is having kids, right? And so it's an essential organ. And so it's not something you just want to remove without a purpose, right? And so I've had patients who come in, why don't you just take it out? You know, and this is not necessarily for cancer, but even just urine, just remove it. Well, there's actual things that come with it. So something that is important just to understand kind of what we're dealing with, and you can kind of understand because of the relationship with prostate, kind of some of the symptoms you can have due to treatment of prostate cancer. We're going to focus on that towards the latter half of my talk tonight. And so what I kind of like to do is kind of break it up into kind of some myths on prostate cancer. So there's 7 myths that are very commonly thought that prostate cancer can cause or lead to. And so I'm going to kind of work through the importances of screening, detection, treatment, and then if there is some time, talk about survivorship, because most men who are actually diagnosed with prostate cancer are going to survive it, right? Only about 3% actually do end up passing away from it. So survivorship is a huge piece, something I actually have a huge passion for doing. And so we'll focus on a little bit of that at the end if there's some time. And so these are the 7 myths that we'll kind of walk through in the pathway of kind of going through screening, detection, and treatment. So one of the most biggest things people think is that it's always going to have symptoms, right? So ironically, prostate cancer, for the most part, never have any symptoms, right? It's typically only symptomatic when it gets very aggressive. And when it gets very aggressive, meaning it's spread to other parts of your body, or it's got very locally invasive. So it's kind of going back to the initial slide I showed you, it kind of has gone from just being in the prostate maybe towards the bladder, and kind of locally invasive bladder. They start having these urinary symptoms, blood in the urine, pain with urination, sometimes back pain, and it's spread to your back. And so typically most people will never have any symptoms. It's not necessarily synonymous to say just because you have an enlarged prostate, you have prostate cancer, right? So many men will get a prostate that enlarges with time as you get older, right? It's just natural hormonal changes after the age of 40. As you get even further on, the prostate is going to get larger. Doesn't necessarily mean you have to have urine symptoms. Doesn't necessarily mean that you have any increased risk of prostate cancer. But an enlarged prostate is important to keep in mind in terms of screening, and I'll talk about that here in a few slides. Now, prostate cancer doesn't just develop in the elderly. Now, that being said, it is a disease of aging, and so I know they've done some studies and anecdotal things as well. It's like if you live long enough, you're going to get prostate cancer, which is in some essence true. However, there's many men who get prostate cancer at a young age. You know, I just diagnosed a gentleman the other day who's 46 with very aggressive prostate cancer, right? Now, those men usually who are younger, a lot of times will have some family history. More times than not, they'll have higher risk disease if they're going to be presenting at a younger age. And they might even have disease that spread. And so in those cases, there's really a role of genetic testing. So there's a lot of genetic tests that are out there. You know, I've had patients kind of get them through their work now. They've gotten stuff done. They've gotten it done. You know, I think just commercially, you can just get it done. But, you know, with Northwestern, we have a partnership. So I'll work hand in hand with our medical oncologists, right? Kind of bridge this gap if there's genetic testing that needs to be done. And then, or so I'll just work directly with the geneticists. And so, kind of as Ashley was saying, and I think you were kind of hinting at, is this whole virtual piece. Well, one of the things that's come with virtual is the geneticists, you know, they're really in high demand, so they're not necessarily that many of them available, which is surprising to some respects, you know, given how much of what we do now is based in genetics. But that being said, they're actually able to do a lot of their screening and ordering the tests and kind of counseling our patients virtually, right? So they're not even on site, they're maybe in downtown and they're able to do that. So I think there have been some benefits to some of the virtual platforms. And so I think genetics does play a big role for certain patients, especially if you have metastatic disease, which is spread to other parts of your body, younger patients. So things to keep in mind. And so, as I said, it's not just important if you have a family history, right? So prostate cancer has a role even outside of family history, right? We talked about aging, talked about it being the most common cancer in men. If you're not aware of that, I think on the advertising for this talk, it's diagnosed in 1 in 8 out of men, right? So 1 out of 8 men in their lifetime will get prostate cancer. Now, with that, a vast majority of people will have localized disease, right? Over 80%. So vast majority of men will never have any side effects from this, will never actually pass away from this. But if you don't treat it, or unless you handle it appropriately, could have untoward consequences. And that's kind of where the importance of detecting prostate cancer still has a role. Okay. Now, there are some unique factors, and we'll talk a little bit about this on the next slide, but it's really, there are some genetics at play, there are some other factors at play. So if you are African American, obviously, no one in attendance audience, but virtually, I'm not sure, almost 2 times more chance of actually being diagnosed with prostate cancer, and almost a little over 2 times of actually dying of prostate cancer. So there are some other things that come into play. Why it's important to kind of look at the overall picture and not just look at just one single data set. And so this is a very busy slide, but I like to put it up here. It's a few years old, but that being said, it's still very, I like to put it up for 2 reasons. One, for something called NCCN, which I think is a great resource for patients. They have a huge patient pathway as well. So I think a lot of your medical oncologist, your urologist, anyone who does cancer care is going to use the NCCN, which has guidelines, right? For pretty much every cancer under the sun, right? Think about it. But it's also very good for patients to look at because they have patient guidelines as well on this website. It's actually accessible. So I think it's a great adjunct. And I tell a lot of my patients who are diagnosed with prostate cancer, if you're looking for more resources, this I think it's a great resource. And there's a couple other resources. And on my last slide today, I'll kind of show you a couple of websites that I recommend. And so with this, when do we screen? What do we do, right? And so I think conventionally, many years ago, and you might remember this and stuff, it was after the age of 50, you get a PSA, right? It was kind of like a colonoscopy. After the age of 50, you kind of got one. However, that's changed, right? And the colonoscopy guidelines, that's moved to the age of 45, and I think even a little earlier, depending on risk factors. And, I'm not going to go too much into that because we're not focusing on that. But in terms of PSA, I think the age of 50 is too late, okay? I think if the age of 40 makes a lot of sense as a baseline, right? I think there's a lot of evidence for baseline PSA screening, right? PSA, for many of you are aware, but just kind of for completeness, it's a simple blood test, right? It's a blood test that can be done along with any other blood test you're getting done as part of your routine, like cholesterol or, your EBC or other blood counts can just simply be done, right? And so when do I recommend someone at the age of 40? Well, if you're African American, as we've already kind of talked about, if you have a family history of breast cancer or ovarian cancer, right? So there's actually other cancers that play in. So not just a family history of prostate cancer that has a role, it's actually breast, ovarian, other types of cancers as well, but those are the biggest ones. And the genes they've identified are BRCA genes, right? So that's very common in breast cancer. Now there's 2 types of BRCA genes. There's 1 and 2. The one that's BRCA2 is actually 2 to 6-fold increase. And so if you were to ever get genetic testing done, right? So I've had patients get genetic testing, even if they didn't fall in the realm of like having metastatic cancer or being young, they just got it done, right? Because these tests are very commercially available. And they look for some of these genes, right? And these genes, if you have these mutations, might be something that you can tell your family member, being like, hey, I should maybe have my son or my nephew or, one of their kids, getting a PSA done at an earlier age and maybe waiting till later, right? I think for everyone else, the age of 45 makes a lot of sense as a baseline, right? Now, one thing I will point out, the rectal examination, which I think a lot of times, and you don't have to show me with the raise of hand, but I have many patients who come to me that they're like, oh, I've never had this done, right? And I think It used to be done all the time because we didn't have as much information, right? The PSA was not as robust. The PSA didn't exist for the early 90s, right? I think it just wasn't there, right? And so the rectal examination had a big role, but it still has a purpose, right? It still picks up the 15% cancers. Now, it's not a hard and fast where it has to be done every examination and in every patient. There are many times we can get away with it, but it still is a very good adjunct in picking up cancers in a more comprehensive pathway. Now, that being said, yeah, go ahead.
As far as the breast cancer linkage, is that really, how many generations should you be concerned?
What they think about our son.
Yeah, and so really it depends on direct relative, right? So you wouldn't want to like, yeah, and so
So
that,
time out.
yeah.
And then,
that would be least breath level, right? So I wouldn't say like great grandmother, I wouldn't say like second or 2 or 3 line, but like direct, right? So when we talk about, I would say like genetics and even like with prostate cancer, we talk about like, like who we screening, right? Like who do we think are like family history, right? Or what really means family history would be like direct, right? Direct parents, direct relatives, like, and more so for prostate cancer, and be directly prostate cancer in terms of the father's, uncle or brothers, and sisters as well, right? As opposed to on the mom's side, right? And I think that would be a little, but that being said, in maternal, right? So if the parent actually, right, for a patient, right? Breast cancer, that would have a role. So I think the simplest way of putting it, I would say parents and then grandparents, and great grandparents, I think it's a little further.
So guess where our son
Yeah.
is grandmother died of breast cancer.
Right, and so I think those are some real, right, I think you could have. And again, I think the further and further you get removed, some of the associations might not. Then it's like, is it really bad or is it more other factors? Okay. And I think one thing I was saying, or it's gonna kind of allude to, just because you got a PSA at the age of, let's say you're 40 or 45, doesn't mean you have to get a PSA every year then. Okay, that's not what I'm saying, right? That's why I think the baseline PSA has a lot of relevance, right? So if your PSA comes back less than 1, it doesn't mean that you should be getting a PSA that every year, right? Now, some people do, right? Some people feel more confident that they want to get it, and that's fine. But in theory, there's plenty of studies that say you can space out that screening. Okay. And typically for most men, you don't have to get a PSA every year. It can be done every 1 to 2 years, right? So you can space it out to even 2 years depending, right? And again, how do we understand how often we get these tests? Is because we have more data, right? There's something called like PSA kinetics. So you can kind of look at different PSA values over the last few years. Oh, it's been pretty stable. I can maybe space it out, right? So you don't have to get it. Now, it's simple blood tests. So a lot of times men will just end up getting it done, But there are costs to this, right? We look at the overall cost of healthcare. We look at various things going on. And so these tests can be done plus treatment. So that's where that baseline test comes in to be a very big importance. Now, that being said, do we need to get a PSA forever? No. I mean, it's the same idea. Do you get a colonoscopy forever? No. Right? There's sure, most tests just don't get done forever, right? There's a very much a futility and continuum type. Okay, so it used to be conventionally after the age of 75. Some will say after the age of 70. I think using age is a little bit of a poor metric because people are living longer, right? We've changed, right? We have a lot more medicines and technology at our fingertips where people are able to get things done and live longer. But I think a couple of things you have to keep in mind: quality of life and your overall health status, right? So if you're in your early 70s, but you're on dialysis and you have, a couple cardiac stents and stuff, I don't think a PSA is something you need to really jump to get done. It's not going to change your overall pathway of life. Okay. Now, that being said, there's a big thing of shared decision making, and for sure, in anything you do when you talk to your physician, it's really involving your patient. Right? So I've had patients in their 80s getting PSA tests done. Not that I overly encourage it, but they just really worry. They have a strong family history, whether it's breast cancer on your maternal grandmother's side, or paternal grandmother's side, or prostate cancer, or other factors that they really feel more comfortable. So we kind of talk about it, but every test has reflex action, right? So just because you have a PSA, what are we gonna do with that information, right? And so I think that's where you have to really can't think about it. It's not, and so as patients will come and say, it's just a simple blood test. Well, it is a simple blood test, but what are you gonna do with that information? And I think that's the biggest thing. And that's what we take into account when we're actually ordering these tests. So PSA itself is not used to diagnose cancer, right? So just because you have a PSA of, let's say, 7, right? So conventionally, we use these numbers, and if you've probably seen your lab test, right? It's greater than 4, right? Okay, so it's above 4, so it means something. In theory, yes, it means something, but it doesn't necessarily mean you have cancer, right? It basically hints us that maybe we need to look into it, right? Because the PSA can go up if you get older, right? It just goes up naturally as you get older due to hormonal changes. It can go up just because you have a larger prostate, right? And so the biggest thing that I like to point out is something called adjunct test, right? So just because you had a PSA above 4 doesn't mean we jump to a prostate biopsy. Or we jump to the next diet. We want to do some additional tests. I think we've learned a lot in the last, I would say, last decade about what to do with the PSA value that's, let's say, maybe above 4, or for younger guys, even above 3, right? There's a lot of literature out of Europe that talks about PSA just above 3. And again, this PSA kinetic thing comes into play, right? So if you've had PSAs have been gradually rising, right? So I've had patients, PSA was 1, following year was 1.5, it was 2.5. That's hit 3, hasn't hit 4, but it's been going up gradually over the last 3 years. That's something that we should be looking into. And so I think just using a cutoff value is not great, right? I think that's why getting a series of information and values is very important. Now, you'll probably see a couple things on here, something known as a prostate MRI, and I'm going to talk more about that in the next slide, but something known as the visual rectal examination, which we do that. So those are some things to keep in mind, right? Just because your PSA was 2 doesn't mean that if you had an abnormal prostate exam or an abnormal prostate MRI that we shouldn't be doing some other things. Because again, the PSA itself is not a perfect test. It's better than nothing, but it's not a perfect test. Now, other things that we can do to kind of help increase the validity of the PSA is repeating it. Right, so a lot of times I've had guys come in, their PSAs have always been less than 1. It went up to 5. I don't know, right? We do a urine test. The urine test didn't have any infection. We talk to them about other things that can artificially raise the PSA, right? Sometimes getting the PSA right after sexual activity can do it. You know, going on a prolonged bike ride potentially. I mean, there's various factors, right? And without going into grave detail on like trying to remember what you were doing right when you got this blood test or not, we simply just repeat the blood test, right? 25% of the time, if that PSA was within 4 to 10, will come back normal, right? And what that really means is that it was an artificial elevation, right? It was a false positive, especially when you've had normal PSAs the whole part of your life, right? So that's when we do that. It's not like we forget about it, we'll repeat it again in a year, but that's something that it's important to just repeat it. Okay. Another thing that can actually come into having a lot of value is something called free and total PSA. So PSA is it's a blood test, right? It's a protein made by the prostate, and most of it's just kind of bound, right? Bound to the prostate, bound to a protein or another protein. The one that's if it's floating around, the part of the PSA that's floating around and not bound, that's great. The more you have of that, it's great. So some people who have very large prostates will have a very high percent free PSA, and I'll talk about that on the next slide. That actually is a very positive thing, right? Have a high percent free PSA. And there's some other biomarkers and that we actually end up getting, which are all end up being, for the most part, blood tests. One of them is a urine test. The one that we use pretty much at Northwestern a lot is something called PHI, which is the prostate health index, which takes into account 3 different forms of PSA without getting into nuances. All these things that are doing are basically putting more tools in our tool belt to kind of help determine when do we really need to do a biopsy and when are we going to get the most field of a biopsy, as opposed to just jumping to them. Prostate MRI, again, very helpful. And what the prostate MRI can help us do is avoid nearly 30% of biopsies. So if an MRI comes back normal, the likelihood of you having clinically significant prostate cancer is very low. So at this day and age, I think most men are getting a prostate MRI. I can't remember the last time I've done an MRI biopsy without having an MRI done. Now, there are times when we can't get it, right? So if you have, sometimes, if you have a pacemaker, there's certain factors at play, that come into play where you can't get it. An MRI, there are factors, right? So those are exceptions, not the rule. For most patients, they're able to get it done. As I was saying, with the percent free PSA, so the more it's floating around, if it's greater than 25%, you can avoid nearly 20% of biopsies. A percent free PSA less than 25% is more likely indicative of prostate cancer, especially the lower that number goes, okay? And again, the abnormal prostate MRI can signify prostate cancer. So again, nothing's a perfect measure, but taking these all into account, we're able to kind of minimize the overall excessive use of prostate biopsies and really increase our yield of prostate biopsy. And so I think one of the biggest things that I think you've kind of gone through healthcare over the years, and as you guys obviously have been in healthcare for many years and seen doctors for years, you kind of seen more and more requires no treatment, right? And you're like just watching more and more. And prostate cancer is not immune to that, right? I think over the last decade, last 15 years, we've learned more and more about the biology of disease, okay, whether it's cancer, whether it's even simply as blood pressure, right? And the management of certain things that can watch things safely, right? And something that's actually done for prostate cancer a lot of times is something called active surveillance. And so you might be thinking, if I haven't already spelled it out, why do we even bother? Over 50% can just be watched, right? Most of it's not going to cause any harm. But there are bad actors, right? And I think that's what it is, right? So there are very bad forms of prostate cancer, right? Like the gentleman I told you was 46, has a very aggressive form, right? There's people in their 60s, they have very aggressive forms. So yes, while the vast majority of prostate cancer is slow growing, indolent, never really going to cause you any harm, there are some really bad actors out there. Those are the ones that come up. So that being said, there's still a benefit for going through all the steps we discussed to pick up those bad actors. So with that, I'm going to kind of talk a little bit about kind of diagnosis, right? So we talked already about screening. We talked about kind of detection, okay? So we're going to talk about diagnosis. This used to be if you know anyone who's gone through prostate cancer, very similar, something called the Gleason score. Now this has been replaced by something called grade groups, which I'll show on the next slide, because the Gleason score was they looked at the cells of the pathology from the biopsy under a microscope. Pathologists looked at it. They looked at two patterns, right? What was the most common pattern? And the second most common pattern, and they came up with a score. The Gleason score from 6 to 10, okay? However, they found that was maybe confusing for patients, right? They did these panels and basically they replaced it with something called a grade group, 1 to 5, okay? Now, grade group 1 basically corresponds to 6 and so forth. Now, grade group 3 is more aggressive than 2, and that's because the more common pattern is a 4, right? So if you look back to the prior slide, I was saying cells of 4, which is a more aggressive type of cell. And so that's why grade group 3 is more aggressive than 2, even though the Gleason score is a 7. And so I think that's where some of the confusion came in for patients. They're like, well, I have a Gleason 7. How is that different? So that's why I just want to grade groups. And so if you ever know if someone's diagnosed with prostate cancer, they'll probably hear that they have these different grade groups, right? And so really when we talk about clinically significant prostate cancer, it's typically people in grade group 3, 4, and 5. And then occasionally grade group 2. People in grade group 1 are typically not considered clinically significant, and those are the ones that we typically end up watching. Now, again, there's always exceptions to the rule, the factors at play, but those are the ones we typically end up watching. Now, in terms of treatment, in one we do treat, right? So as I said, if we do have more of an aggressive form of prostate cancer, there's other factors to play, family history to play in, right? Whether it's directly prostate cancer or even genetics that you have, maybe a BRCA mutation in as part of your workup you've gotten that done. And those are the things that we start talking about treatment. And so I'm going to walk through all these different treatment options in relation to kind of one of the biggest things that I'll have many men come in and talk about is that erectile dysfunction, right? So it's a very common thing, erectile dysfunction, even outside of prostate cancer and stuff. And what I want to bring up is that people think that prostate cancer itself causes the erectile dysfunction. Don't think that urinary symptoms cause erectile dysfunction or it's related. There's actually no real relation. It's really the treatment that actually causes it. And so that being said, most men will actually regain function if they do undergo surgery, right? Within 1 to 2 years. However, it's additive, right? So if you get radiation, you might not necessarily have side effects right away, but you have side effects over time. So it's really the treatment for anything prostate cancer related that leads to some of these side effects. And that's why we learn in terms of the genetics, in terms of the biology of the prostate cancer tumors, is that watching these tumors is very safe and actually a better quality of life and better survivorship outcomes for a lot of patients. So we don't necessarily treat every cancer that comes in the report. 15 years ago, it's a different story, right? Because we didn't know. So I'll focus on one of the mainstays, surgery, right? Surgery at this day and age, I would say about 90 or 95% of it is done robotically or laparoscopically, right? So robotic surgery, which you're not familiar with, is pretty much using a piece of technology to kind of make laparoscopic surgery easier, right? It gives the surgeon who's doing the surgery more degrees of motion with their hands, right? So they can actually sew parts of things that they need to sew and reconnect better. They can get to certain parts of the anatomy in the pelvis, which is a very deep area, which is where the prostate lies, with more degrees of freedom, simply put, right? That being said, it's typically done as an overnight hospital stay. Now, there are some surgeons who send people home the same day. It's a exception, not a rule. So it's typically an overnight hospital stay, sometimes 2 nights. You're having a Foley catheter for about 1 to 2 weeks because you take away the prostate. So if you remember back to one of the first slides I showed you, to take away the prostate, you have the bladder in the urethra, right? There's a hole, right? We have to connect that back. It's that catheter ends up letting those things heal. It's a minimum of 4 to 6 week recovery where you can't do any heavy lifting, more than 10 or 15 pounds. Then kind of getting back to usual activities. I've seen that lingered about 3 months. So it's not something that you're right back. And so and then some of the side effects, again, infertility. Obviously, we said the prostate is instrumental in that, so you're going to have that. And then some of the other things we talked about already. Now, radiation, this is kind of a lot of things, but again, side effects are not, radiation is not free of side effects. There's many different forms of radiation. And I think I have that in my speaker. Slide 2, but basically there's different forms, right? There's proton beam, there's external beam, IMRT, there's brachytherapy, and there's something called cider knife or stereotactic, like SBRT radiation. And so that's very targeted, high intensity, shorter treatments in terms of number of treatments. So typically, IMRT or EPRT is typically 20 to 25 treatments. And really, a lot of this has changed, right? Conventionally, when I started doing this, it was always 40 to 45 treatments for radiation, right? Now they do something called hypofractionation. Without getting into the technical nuances, what they've basically been able to do is like, it's a balance, right? So radiation has toxicities, right? If you do too much radiation at once, you can maybe increase the toxicities, right? So what's the balancing point we can do to kind of minimize the number of treatments, right? Because no one wants to go in every day, even though it's like 10 or 15 minutes, it's not that long, but it is every day, and not on the weekend, but still Monday through Friday. So can we get it down to 25? Can we get it down even further, right? And so they've kind of done studies on it, and obviously work hand in hand with radiation oncologists to kind of figure out what the best scenario is for each patient, right? Now, that being said, no form of radiation is free of side effects. They might not have side effects right away, but if you live long enough, 5, 10, 15 years down the line, you'll have side effects from radiation. Not everyone, right? There's always exceptions to the rule, but that's waste radiation side effects they have accumulate. Also down the line, and I've seen this, and again, it's rare, so it's not to say it's a very common thing, up to 2% incidence of secondary cancers with radiation. Right, so I've seen patients who had seeds put in or brachytherapy, they developed bladder cancer. Now, again, can I say that was directly due to the radiation? I mean, there's other factors, right? Everything has multiple factors. Could have been your remote smoking history or remote, but they're at risk. There's been studies where people developed colon cancer from radiation again, down the line, like 15, 20 years down the line. So there is incidence of secondary cancers. That being said, you know, and these are some other types of targeted therapies. Nanoknife is not a form of radiation. Something like it's basically using electrical pulses to kind of do targeted. So basically, all these therapies are something called focal therapy, so kind of targeted therapy, and when you've been diagnosed with prostate cancer. And they kind of study patients with kind of low risk and maybe kind of that middle risk prostate cancer. So people in the grade group 2 and 3 be like, hey, can we do some focal therapy as a first line treatment? Again, there's not long-term data. There are people that do some of that. There's a gentleman downtown in Northwestern that does some of the stuff with the bioablation. People do the HIFU and other things. And again, what I tell people is this, these also have side effects, whether it's short-term, infections or leakage of urine. And really the long-term data is kind of lacking, like 20 years down the line. So it's available, not to say it isn't. It's something that, again, it's, who knows, over time. And so I think that's something to keep in mind. And I think where the data is really robust is, let's say if you had radiation up front, and if you have localized recurrence, maybe just in one area, these therapies have a great function. And then kind of switching into kind of this is a very busy slide, but to kind of be complete in terms of treatment, right? And so this is where we work hand in hand. Again, I think what's changed also over time, I think in the last, I'd say 15 years or so, is kind of the multidisciplinary approach, right? And so I think what you'll see at Northwestern, what you'll see a lot of those places that do a lot of cancer, it's kind of a multidisciplinary approach where we're involving the geneticists if we need to, we're involving the radiation oncologists they talk about, and we're involving our medical oncologists, which is kind of coming in, right? And so we'll work hand in hand to be like, okay, so if the cancer is spread, what can we do? Chemotherapy actually has a role in prostate cancer, but it's almost like toward the bottom. So vast majority of men will end up getting things that work on the hormonal axis, right? Basically cutting down on the fuel to the prostate cancer, right? There's a lot of drugs. I mean, there's probably like 6 or 7 drugs that's out there my head I can name that work on the hormonal axis to prostate cancer. And this can work if you have very high, even if you have very high volume prostate cancer that's maybe just locally advanced, right? Maybe not spread everywhere, right? So that's kind of what we're talking about. Now, hormone therapy, right? So basically like cutting down on the fuel to prostate cancer, right? Something like cutting down on the testosterone and stuff. I liken it to male menopause, has a lot of side effects, right? Those side effects include impact on cognitive decline, dementia, complexities, weight gain, heart disease, going out. So for younger patients, there is a newer drug that's come out that kind of these conventional hormone shots that we used to do every 3 to 6 months. There's a pill form actually that actually has a way to drop someone's testosterone really rapidly, which is great. It actually is able to help you regain some of these adverse side effects to kind of overcome like the impact on energy and libido and all those things very rapidly. Okay, once you're off the medication, and then additionally has about 50% less chance of cardiovascular, so heart disease, like other heart side effects. However, the kicker is it's not routinely covered all the time. So again, over time we'll see what will happen, but that's definitely for younger patients who are going to be on these medications long term, and they say, yes, we want to try to get them off of it and got to get back to your steady state, something like that. Definitely we'll talk to patients about. again, working hand in hand with our medical oncologists, trying to serve which patients will be best with that. So with that, kind of break it up. I don't know if you guys have any questions. So that's kind of the main focus on a lot of the, as I said, kind of prostate cancer, what it is, kind of why we screen for it, how we detect it, and then kind of treatment. And we'll spend the last few minutes here kind of talking about some of the issues that most men who have prostate cancer, if they've ever had it treated, will end up unfortunately facing.
One of the questions I had is, as far as the sequencing of the events, there's the diagnosis, the detection, the diagnosis. From the biopsy to a surgery, is there got to be a waiting period, or is there, does it all depend on what you find in the biopsy to determine the aggressiveness or the non-aggressiveness or something?
So that's a great question. So the minimum is about a 6-week waiting period between a biopsy and any type of treatment. The reason is it's very inflamed, right? So if you go in and you're all the tissue planes, right, you're going for surgery, it's going to be a mess, simply put, right? So it's just the outcomes you're going to get from surgery are not going to be ideal, right? So typically you're waiting 6 weeks. Now, that being said, during COVID, right, a lot of things were being delayed, right? So they actually have people who publish literature on delay of cancer care. Not necessarily intentional, it just happened, and people did fine. And so I typically tell people from a diagnosis, depending on if we're going to do treatment, right? So let's say you have a cancer that's in the other 50%, not the 50% watching. You want to try to figure out what you want to do within 3 to 6 months. Now, the 6 months can be for, like, it doesn't seem like the PSA was so aggressive and be high, and the pathology wasn't so aggressive, then maybe we can wait that 6 months. If we diagnose you, let's say, in the springtime, and you're like, well, I have a busy summer, I don't want to take time off, I want to do it in winter. That's fine, right? We can safely do that, right? So it's just a case by case basis. But in terms of your initial question, yeah, there is definitely an initial waiting period of about 6 weeks that most surgeons will kind of adhere to. And in reality is this, most people you're not even able to get in to do a surgery right away because of whether it's not even the surgeon's availability, that could be one factor, but it's, again, another reflection of COVID, right, is the reality that we see in every facet in every industry in our society is shortage, right? Whether it's healthcare shortages, right? Operating room availabilities. So again, it's a reality, but it's also a reassurance piece where you can safely wait and you're not going to really have an adverse outcome. Any other question, Brandon?
I have a question here. So genetics. So you are more predisposed to prostate if you have the BRCA gene, the breast cancer on the mother's side. What about the flip side of that? So if you have a father who has prostate cancer, are those children, female children, more likely to have breast cancer? Does it flip flop?
I would say so if they had a genetic
Okay.
thing.
Just
So
curious.
if the gentleman had prostate cancer, the father, if they had a BRCA mutation, then I would say that,
Got
right?
it.
Because if they didn't have any genetic,
Then it
then I
doesn't cross
wouldn't
the
say
sex
that,
line.
right? So
Okay.
again, something that, and I think as we get further along, right, and I'm sure you could speak to this, you've kind of seen a lot of patients who've gone through their cancer journeys. Genetics was not being done that often, right? It wasn't that easy to do, right? It was a whole process, but now I think they're just like, they mail you the kit to your home, it's a saliva sample, it's very simple, it's very easy. You get results within a couple of weeks. And so it's become very streamlined. And so I think as we get further along, another 5, 10, it's just gonna become just more and more. So we're just gonna have that information at our fingertips, right? Again, what does that mean for prostate cancer besides maybe screening earlier and maybe being a little more aggressive in the frequency of our treatment? It's not like we're removing prostate prophylactically, not like, we're doing treatments like that with breast cancer. But again, who knows? Over time, things might change. But right now, it's
I will shamelessly plug too, we have a genetics talk coming up in February that's been confirmed. So if anybody wants
no,
to
it's great.
learn more about genetics, we're having a genetic counselor come speak in February on just this thing. So stay tuned.
Can I clarify, the question about getting a biopsy, and the time length between making a decision versus surgery? That's a decision about any type of treatment? Like, is usually 6 to 8
Pretty
weeks,
much,
or
right.
just about surgery?
Pretty much any type of.
Any type of
I would say,
treatment,
yeah.
okay.
Even with radiation, I mean, because radiation, so there's different forms of radiation without going into nuance, but let's say you're gonna get seeds put into the prostate, like brachytherapy. It's inflamed, you're not gonna be doing that right off the bat, right? Number two, you're gonna do something called planning, right? So if you're gonna get external beam radiation or IMRT or even proton beam, right? There's mapping and planning, right? And so those things take time, right? So it's not like, again, there's no like rushing. Now, some people what we'll do, right? To your point, Angela, is if it's a very aggressive cancer, right? And we know we're gonna do radiation, we'll get people started on cutting down on the fuel to the prostate cancer, right? So like androgen deprivation therapy. Number two, if you're symptomatic, right? Like, so let's say you have prostate cancer and you have spread, right? Let's say it spreads to your bone, right? One of your bones by your hip. It spreads to your back and you're having pain. They can do palliation to those areas, right? So they can start treating that. So it's not like you're, but the treating of the primary prostate is usually related to some degree. So there's nuances in place. So again, individualized to the patient. But if we're looking at a kind of overarching umbrella type answer, yeah, usually about 6 weeks or so.
And can I ask one more question before you get into survivorship? You talked about metastatic treatment options, and is there something called Lutathera that's a new treatment option?
You know, the generic on here right now.
I thought it's something new for metastatic prostate.
Might be, I think,
Okay.
look, I don't feel like there's a lot of.
The radioisotope that they're using?
Oh, yeah. I mean, so there was something called, and I don't know if this is, it might be in the line of something known as radium-223. It was like Zolfigo.
Yeah.
And so I think it's in the same line. I think it's that. So that's actually for, not necessarily, it is for metastatic prostate cancer. And it's kind of in that pathway of when we're using some of these newer drugs that you probably come across, like abiraterone or Zytiga or isobutamide. And so it kind of falls in that same pathway. So I think Lutathera is newer, so I'm not familiar with that.
Or it's Zolfigo, I think those.
Zolfigo is.
More the familiar one that.
Zolfigo's older, and so basically, if you have typically castrate-resistant prostate cancer, which basically means prostate cancer that it's spread, so it's metastatic, and then castrate-resistant, meaning that it doesn't respond to hormone therapy, right? So basically what means that cancer keeps growing, the PSA keeps going up despite just getting hormone shots. And your conventional primary therapy, if you had it, then this kind of fell into the pathway. But there's other factors at play, there's other nuances in play, how many sites of disease burden you have, and again, going back to working hand in hand in a multidisciplinary approach to identify, right? So prostate cancer's gotten very much more confusing, right? In some respects, to simply put it, than what it was 10, 15 years ago, because there's so many different things out there, which is great for the patient, because you don't have just one line of treatment, right? It's not like surgery, radiation, chemotherapy, that's it. Or basically hormone shots. No, there's 7, 8 drugs, and then there's this stuff as well, so.
Sorry, just another quick one. On the surgical option, is it all or nothing? Is there a way to treat lesions, but leave the balance of the prostate?
Yeah, so that kind of goes back to this idea of focal therapy, right? It's so it really is an experimental thing, right? Where there's clinical trials. And so for surgery, there's never been like a partial prostate, right? Because it doesn't really take care of the issue. Now, there are people who try doing something. And again, the outcomes were they're trying to really do it for localized, very much lower risk prostate cancer. And then that begs the question, do those patients even need that treatment, right? Because a lot of prostate cancer can be just watched, where those patients have just been safely watched for another 3 months, whether they need a treatment, right? So again, any type of treatment, but there have been people who have done something called sparing the prostate capsule and kind of doing like a subcount. Again, it's not a great thing, and I think those types of things are done in settings of clinical trials. So yeah, there are urologists around the country doing some of this stuff, but it's not something that's conventionally offered here in Northwestern, whether that's And so when I speak of Northwestern, I speak of like about the 16 urologists who are part of the suburban network, stretching all the way from like McHenry out to like DeKalb, right? Whereas I'm censured and obviously most of the patients who probably come these, obviously resources over here and Warren over in Geneva are basically going to our offices in Delaware or our offices in Winfield, which are across from the hospital. But then also speaking for the urologist in downtown, right? So there's another 12, 14 urologists out there, basically viewed and specialized in just prostate cancer out there. And they're not doing any of that either. And so really no one in Northwestern is doing focal treatment, and there's really no role, and no research that I've seen on just partial prostate surgery.
Thank you.
So with this, I think I bring this up, and I think it's a very important topic. One, I enjoy a lot of it. I see a lot of patients. I do pretty much all of this for our group in the suburban practice, as I was saying, with 16 urologists in terms of treating patients who not like just not just erection issues, but who kind of fail multiple other things, right? Kind of the survivorship realm. And that's kind of how my partnership actually did start with Living, where I was talking to about the survivorship. And I think is becoming a bigger and bigger piece for anyone who has any type of cancer, because you're going to live with cancer. You're going to live with cancer, right? You're going to overcome it because our treatments become so great. It's good, but you have side effects. And what are the things we can do to solve these side effects, right? It's very prevalent. I think we talked a little bit about that. I think 1 in 2 men after the age of 40, almost 40 million men. And you can kind of see it's pretty high, even after radiation, right? So some people think I got radiation, I'm not going to have any of these side effects. It's common, right? Obviously after surgery. So what are some of the treatment options? I think this is very much marketed very heavily because it impacts a lot of quality of life. It impacts, right? It impacts patients' mental health, it impacts relationship with their significant others, it impacts physical functioning, a lot of things, right? And so I think that's why it's become a huge thing, right? That's why I think if you watch any sporting event, you'll see like multiple commercials about this stuff. You drive by billboards, right? And I think, unfortunately, there's a lot of things that just don't help, right? And I think that's where we come in as urologists to kind of help provide options that are going to be things that are not going to get you more frustrated, right? And I think you've all heard of medication. Medications are all generic at this point. They're like pennies on for most of these prescriptions, right? It's not like you can get it through your insurance. Your insurance won't still give it to you for the pennies. You have to play. It's a system game, right? You have to end up using something called GoodRx, or you can go online through like, Cost Plus, and Mark Cuban is at his pharmacy. And again, you can get all these different things, but there's no reason where this medication should be cost prohibitive for most patients this day and age. Again, that being said, medications don't work, and it doesn't work for many patients. There are other options out there, right? There's injections, there's erection devices. And again, the things on the far left or your far right, if you're looking at the screen, don't usually work that well for most patients, right? They're there because it's just for completeness, but really the 3 mainstays are medications, injections, and surgery, right? And people think that surgery is seems very out there, and actually it has the highest satisfaction. These are types of surgery that are there, but it's over 95% of satisfaction. I think the reason I bring it up, there is an option out there, right? You don't have to live with it. Now, that being said, if you are okay living with it, that's totally fine. But I think the education piece, I think, is the biggest thing that what we pride ourselves on in our practice as urologists here out in the suburbs and even downtown, just being educated of what's there. Okay. There's other things that I'll bring up just for completeness sake, and stuff that I haven't talked about here. Was for incontinence is that, just because you have, you kind of fail some of these things, and they'll advertise about something called shockwave therapy. They'll talk about PRP, which is implanted plasma. And these are things that a lot of our clinics in the area are doing that are these men's health clinics, right? That are unfortunately more times than not actually managed by anyone who's a urologist, managed typically by people who have no urological training whatsoever. And it's unfortunate, right? Because for the vast majority of men, those things don't work. And and it's more of a case by case thing where, yes, you might get some benefit, but they're usually short lived, not covered by insurance, very cost prohibitive for most patients. So I've seen patients who've gone through some of these pathways, fortunate where, again, not to say it can't be offered, right? But you should be aware of when it's being done, and what kind of things with realistic expectations. And so with that, I think one of the other things I'll bring up, that's a very common side effect of prostate cancer, any type of treatment, radiation, surgery, is leakage of urine. Leakage of urine just happens as you get older, unfortunately, right? There's actually a slow inclining curve that you'll look in papers that people just have more frequency of urination. But again, it's not really the prostate cancer that causes it, it's the treatment. And you don't have to live like that, right? I think one of the things, again, most people just, men are not immune to this as females, right? Most females will come to me with a urinary complaint 2 to 3 years after having that issue, right? They're not coming right away. They're using multiple pads, multiple, sometimes the pens, things like that. Same thing with men, they're not really seeking out that care. And again, it's really about the quality of life, I think, and understanding that you're going to be living for a while, right? It doesn't mean all roads lead to surgery, right? There are other options, right? It's that there is an option, right? The pads, the pens, the diapers, if you feel embarrassed to go out in public, right? You're like, well, I don't know if I need to, someone to sell this. It's not covered by insurance, it's extremely costly after a while. I mean, again, some coverage is there, some, but again, it's one of those things that it might not be the best solution for those patients, right? I mean, and that being said, right, there's something called physical therapy, right? Same idea for women. This is a lot of times being taught to our patients before they undergo prostate cancer surgery. We'll work with our physical therapist. This is specifically for men's health, right? Similar to for women's health, right? So it's not like your orthopedic physical therapy, right? Or if you have broken bones specifically targeting it, it helps. But for some people, it just doesn't do it, right? And so when these things don't help, you don't have to live with it. This is a great option, right? I've had patients use this, but again, some people find it barbaric, archaic. But that being said, it's a very inexpensive option that is available, right? That can maybe minimize how many pads and stuff. But for some people, you're like, this is just not what I want to do. I want something that's going to get me back to my daily activity. I've had patients who golf and they're like, I can't make it beyond one hole to the next without running to the bathroom or leaking, right? And so for those people, whether it's that, whether it's just going traveling, right? Simply going on a cruise ship or going overseas or anywhere, right? And having to worry about finding a bathroom or having to find a change of clothes. And regaining some of that dignity and stuff. There are some surgical options. And there's two mainstays. One is a sling. It's basically, again, so we kind of go back to that first slide I showed. The prostate is the pelvic floor support. So if we don't have a prostate, those muscles have to be retrained. So you retrain them, right? You tried that with the exercise and the physical therapy, just not getting there, right? So this is providing that extra support. If it is an outpatient surgery, again, minimal leakage. If you're leaking too much, this is not going to work. Okay. If you're extremely overweight, it's probably not your best option. Okay. And for those patients, there's a more definitive option. This thing called an artificial urinary sphincter, where basically, if you look down, is basically around the urethra right here, and then you're using a little button right there when you want to urinate, right? You push that, it cycles, gives you 60 to 90 seconds, you urinate, cycles back, pushes pressure. This device, unfortunately, only lasts 5 to 7 years, it has to be replaced. Now, again, newer things are coming out. There's a lot of things in the pipeline where they're trying to make it automated, where you don't have to even press the button. Because sometimes what happens is patients, unfortunately, as they get older, have dexterity issues. And so that could be a plague, right? And so there are some things that are coming out. And hopefully over time, there'll be a longer device, right? That lasts longer. That'd be something. And so with that, kind of going back to what we talked about and how we started today, is that, prostate cancer, the goal now is to really detect clinically significant prostate cancer, right? Biopsies have risk. The risk from a biopsy this day and age, the way we're doing it, it's not conventionally done in the office. It's actually in terms of like where you're awake, a lot of times we're doing the biopsy, at least out here, we're doing it in operating with a little mild sedation, which most patients don't ever mind anymore. Two, we're doing it with a different technique where we're actually targeting the through prostate through the perineal region, which is the region between the scrotum and the rectum. And with that, we basically, the risk of infection is almost zero. Okay, versus the conventional biopsy that was done. And it's still being done. I would say about 80% of urologists in the area still do that conventional biopsy. But I would say about almost everyone at Northwestern does a transperineal biopsy, which serves the purpose of minimizing infection, getting a better yield of the biopsy to help us, again, detect clinically significant cancer and not really diagnose unnecessary cancer. Number two, I think there's no perfect screening test, right? As we talked about, the PSA is great to kind of help guide the discussion, but that alone doesn't change anything. I think we talked a little bit about genetic testing. I think that has a very big role. I think the role is only going to get bigger. I think the other piece that we want to understand is that prostate cancer itself, it's not really cause any side effects for most of it. Right? Again, it can, not to say it doesn't, right? There are the aggressive forms and ones that spread in a spread diagnosis, but that's rare, right? And it's really the treatment. And since the treatment does cause side effects, it has significant quality of life issues. And I think these quality of life is a big piece, right? Because when we talk about any type of treatment, we want to look at what are the lasting impact, right? And so I think we think back to why don't we keep treating prostate cancer until the age of 90 and keep working for it? Because quality of life is very important. Right? And that impact that treatment has on quality of life does not have to be permanent. And with that, I'll kind of leave this slide up. There's some great, I think, resources, outside the NCCN website that I kind of alluded to. I think urologyhealth.org is great. It's by the Urology Care Foundation, which does a lot of partners with the American Urological Association. We do a lot of outreach and a lot of different talks and stuff like that. Great resources available there. Serial cancer and some other stuff. And then so some resources out there. I mean, there's tons out there, and I think I like to show these to kind of guide patients, things that kind of help streamline stuff, because again, you can kind of get lost on the internet, unfortunately.